Yeah, cool.
Yeah.
Great. So being asked to teach AMPs about falls and syncope, you probably know quite a lot because I'm guessing you've all seen the odd fall. So hopefully I'm not just going to teach you to suck eggs, but we'll see how we get on. We'll talk a little bit with some case studies. We'll talk a bit about risk factors, investigations and management of falls, and talk a bit about medications, when we need to CT scan, because that's normally what people worry about the most, I think, and then a bit about syncope and the indications for investigation. And I guess falls is an important topic, partly because it's on your curriculum, as it is on mine, and partly because falls are bad. So this is taken from a website from solicitors, and it's a hospital basically were fined a lot of money because one of their patients kept falling and he subsequently broke his hip and then died. So falls are important because people die and they get there's significant pain and often they're preventable. So I guess it is worth talking about them quite a lot. And I've got this picture of a rock pool because I was just, to get an idea who's here, going to ask everyone to say hello. And just, if you have fallen recently, it would be useful to know. And I fell in a rock pool on holiday, so this is just a reminder of me. So I will ask everyone to just say hello and say where you're from, and maybe how long you've been an AMP. So I'll go in the order of my screen. So Christopher Bott, you're first.
Hello. Oh, hang on.
Hello.
Hello. I'm Chris Bott. I'm a lead ACP for Hospital Night at Rotherham, and I've been an ACP for over 15 years.
And have you fallen over recently?
Only when drunk. But I don't like to talk about that on screen.
Okay, great. Next is Lucy Broadhurst on my list.
Hello, so I'm Lucy. I work up in cardiology. I actually run a syncope clinic for cardiac patients up here, and I have fallen over before. I fainted actually when I was when I put my first pacemaker in. I actually fainted in the lab, rather embarrassingly. So there you go.
That is a great story. And maybe telling you some things that you already know, and you might be able to add some more stuff to us later. Ed, you're next on my list.
Hi, I'm Ed Davison. I've been an ACP for about 2 years. I'm sorry I'm in the swimming pool at the minute. I've fallen recently. I've tripped over a curbstone or something, so I didn't pick my feet up.
Helen, you're next. I'm shaking your head. Helen, do you want to say hello again? You're on mute, Helen. You were the first.
I know better now. Sorry. Yeah, I'm Helen. I've been ACP for 8 years, and have I fallen recently? I can't remember falling recently. I probably have, but again, probably similar to Chris, in a drunken state that I probably shouldn't be discussing on this forum.
Next, I've got Tracy Edge.
Hi. So there's a group of us actually with the cardiac physiologist at Rotherham. I've been asking around if anyone's had a fall recently, but they're all denying it. So, but we're all a very sober bunch, so we tend not to fall very often.
Hi. Next is Eddie.
Hi, sorry, I can't really show my face. You don't want to see. You can hear. From the background. Yes, my name is Eddie. I'm one of the MPs in Sheffield, and I've fallen before. It hurts so much.
Oh.
Can you hear me?
Yeah. So
I actually tripped from my stairs. I just missed a few steps, and then I landed on the floor. So, yeah, I have fallen before.
Thank you. Next, I've got Lisa.
Hello, I'm the TACP for Hospital at Night at Rotherham Hospital, and I haven't fallen recently.
Good. Next I've got Leah Robertson.
Hiya, I'm Leah. I'm one of the ACPs from Rotherham Hospital at Night as well. Been an ACP for about 3 or 4 years now. Not fallen recently, I don't think. And if I did, it was probably heels, not alcohol. I'm going to go with that one.
Rachel, I've got you next.
Hi, I'm Rachel. I'm AMP at Sheffield. I've been an AMP for about 5 years, but usually I'm pretty clumsy, but I can't remember a fall recently.
That's fine. Sarah, you're next.
Can you hear me?
Yeah.
Oh, fab. I'm Sarah, I'm one of the ACPs that works at Sheffield Teaching Hospitals. I've had quite a few falls whilst intoxicated, but other than that, nothing really, to be honest.
Thanks. Nazia?
Hiya, I'm Nazia, ACP. I used to work at Sheffield, now I work at Rotherham. No, I haven't had a fall. I did fall off the treadmill once, but that was like years ago when I could run like 100 miles per hour. But that were it.
Thank you. And Lorraine?
Hi, can you hear me?
Yeah.
Hi, I'm Lorraine. I work with Hospital at Night at Rotherham. I've been there for about 5 years. I have had a fall recently, but it wasn't my fault. I actually fell from a horse riding accident. The horse fell on me, and it was extremely agonising, and I was in couldn't walk for a few days.
I see. Lorraine, did you used to do orthopaedics in Doncaster?
I did, yes. Hiya, how are you doing?
And I think Joanne joined us. So Joanne Briggs, we've not done your idea, I don't think. Maybe not. And Jess, I think you joined late as well, in out of order of nothing. We've lost the last two. Okay, well, if I've missed anyone, shout hello. So I will start. I'll try and make it slightly interactive, because otherwise it just gets really boring and you'll get sick of my voice. So the first bit, you will have heard all this stuff before, but it's always quite nice to recap. I still found myself looking up some of this stuff. So I guess this is a sign, a fall sign, and falls are a sign. So they're a syndrome, not a diagnosis, and it's basically warning you that something has gone wrong. So it's normally a combination of things rather than one thing alone. But just, I guess, the thing to remember is just thinking about why this has happened. So in the chat, can you write 3 risk factors for falls? Probably the most common you've seen. Hopefully everyone can see the chat box. So we've got delirium. Any more? I've already said alcohol. I haven't got high heels on the list. Yeah, medication, frailty, infection.
By environment.
Environment, yeah. Mechanical clothing, environment. Great. So I've got a list as well. So we said before that it's often a combination of things. So in particularly the geriatric population, we see loads of these things. But as we've already demonstrated, young people can fall as well, often a combination of alcohol and high heels. But there's loads of reasons people can fall. So weak muscles, poor balance, orthostatic hypotension, foot problems or footwear issues, cognitive decline, vision and hearing problems are really common, and in the hospital we often take away the aids or lose them or give them to someone else with the teeth. Medication, as we said, alcohol, Continence issues are a really big problem, particularly in the hospital again. If somebody normally can get to the toilet at home, often they're miles away in the hospital, they're in a rush and they fall. Cardiac disease, and as we said, environment. So this is an example of a request to do a falls review. So an 82-year-old has had an unwitnessed fall. He's in the hospital because he had a delirium and he has a UTI and he's also frail. And he's got a background of dementia, hypertension and AF. So he was found by the nurse on the floor near the window, managed to get up and walk back to bed, but now he's more agitated than normal. And the request is, can you come and do the standard falls review and consider sedating him because they're busy. So at this stage, this is where you guys do these reviews all the time. And rather than me tell you what I think you should do, I was going to get you to just try and come up with 3 of your top tips. So if we were back in August and you had a load of new F1s that were coming to join you and they went off to do the falls review, what 3 top tips would you give them? And I think if possible, we can do it in a breakout room so you can talk to each other. So Helen, if you're able to do 3 breakout rooms just for a couple of minutes, you can maybe actually speak to each other. The issue of doing this is I can't do it because Helen made the meeting, so we'll see how she goes. Do you think you'll be able to manage, Helen?
I think I've done it. Is that right?
Probably. Oh, we'll just let us listen. You just might need to refresh it because we've just got a new person and otherwise they'll be missed out.
Okay. 3 rooms, yeah.
Yeah, so it's just an opportunity to say hello to the other AMPs who you may or may not know, and then just kind of think of 3 of your top tips for the new doctors that join, and we'll just do maybe 3 or 4 minutes and then come back.
There's the opening. Hello. Sorry, have I done that right, Sarah? Sorry, I can't hear you.
It hasn't put you, me or Catherine in, but everyone else seems to have disappeared, so we can just be a room here, that's fine.
Hi, Catherine. I don't know if you just joined us, but we're just moving to breakout rooms to discuss sort of top tips for junior doctors who have just started. Considering
I don't know what I've done.
We can be in a
fine. I feel like you two probably.
Oh, there we are. There we are. I've got in. Am I the only one here?
So we're in small breakout rooms. So I think me, you and Sarah will just be in our little group. So that's fine.
I just I left because I thought no one wants to talk if I'm there. So I don't know, did you set a timer for the breakout rooms or were you able to close them?
I think I can close them. Yeah.
Okay, fine. We'll give it another minute or 2 and then I'll put my thing back up.
Hi, Erin. Have you got any top tips, Catherine? What would you suggest to people?
Top tips for what?
Sorry, for doing a falls review. What, like, if you had to give a new doctor any top tips, like what would your top tip be?
Talk to the nurses and the patient. Because sometimes the story can be very different. That's what get the story from the nurse who saw it and the patient as well. Trying to think of other things. You got me on the spot.
I was thinking about don't be convinced by somebody who can walk back to bed, because I've seen people walk on fractured knobs.
Yeah.
Rarely, but
Yeah.
it does happen, doesn't it?
Leave alone.
The story can change as well. It's
So go,
yeah, sorry.
go on, Catherine. Do you want to close the rooms? I don't know if you can give them a warning. I can't remember. You're on mute, Helen. Sorry, you're trying so hard to get your voice out.
Sorry. To make an announcement. Is that's me? Is it?
Oh yeah, make an announcement for, I don't know, 1 minute, and then we'll close them. Do you want to? I'm going to get everyone to put theirs in the chat. Catherine, do you want to write yours in the chat about asking the nurses?
Yeah.
Mm. And hopefully everyone will reappear.
What am I supposed to be doing?
Do you want to write your top tips in the chat?
Oh. I think it's just yeah. You got me on the spot.
Shall I write your one about nurses? Speak to the nurses.
Say it again.
I'll write your one about speaking to the nurses and the patients.
Oh yeah. Sorry, I'm not very comfortable on Teams sometimes.
I've written it in, so you should be able to read them in a minute. Everyone else will put theirs in when they come back.
Yeah.
Shall I close the rooms?
Yeah, go for it.
Oh, we're back.
Oh, we're back.
Hello.
Is everyone back now? Have we got the right number of people? Yeah, okay. Yeah, you get everyone to mute. I think
Just turn the camera.
Helen, you might be able to mute everyone from your end. There you go. Okay, so in the chat box, if you can write some of your top tips, that would be helpful. So we had a small group, and Catherine's top tip was to speak to the nurses and to the patients to get the story. I'm sure you've all got good top tips to tell the F1s. And Helen was saying, just don't be fooled by the people that stand up and walk back to the bed. She said she's seen some NOFs, I've seen some NOFs when people have walked back. So top tip number 1, a thorough ATE assessment. Agreed. Any more? Give it a second. Okay, so review the medication, another A to C and a neuro exam, and a full body check. Agreed. And yeah, so look out particularly when looking at the medication to see if they're on anything that will could make you bleed, and think about a CT head. And I think, yeah, the blood sugar and a proper musculoskeletal assessment is good. And I think we often forget the blood sugar, I think. So I guess the point of doing a falls review is basically to recognise whether they've had an injury, to investigate the cause of the fall and the injury, and then prevent them having further injury or something going wrong, including death. So that's why it's important to do thorough falls reviews. And I'm sure you have thought about things like this before, but often think about before, during and after. So we want to know what happened before the fall. So what was the environment like? And what were they doing when they fell? Did they have their socks on? Were they at the end of a dark corridor and they didn't know where they were? Do they have their glasses or their hearing aid? Do they know where the toilets are? Were they trying to get to the toilets? Do they normally have a walking aid? Did they use it? And then did they have any symptoms? And then during the fall itself, did anyone actually see what happened? How did they land? Did they lose consciousness? Was there any seizure activity? What else happened? What did they look like if someone witnessed it? And then back to after. These are my least favourite thing in the hospital ever, because no one ever seems to know how to use them, but they appear. But you guys are probably much better with them than I am. So did the patient manage to get up? And as Helen said, just because they got up doesn't mean they're not injured, so don't be falsely reassured. And then you want to know what their observations, their GCS are, what their cognition is like, are they in pain? So I quite like the before, during, after way of approaching things. But I also, the way I kind of remember things often is start at the top of the body and work down. So I sometimes run through this way as well. So kind of think about have I addressed their cognition? Have I thought about their vision? And I guess hearing comes into that as well. Have I thought about their medications? How do I need to do an ECG? Have I thought about the ECG trace, their heart? Have I thought about the blood pressure? And that includes a lying standing blood pressure or a 24-hour blood pressure, as well as just the routine obs. Have I thought about continence issues, either before the fall or now they've had a fall? Have I thought about sarcopenia? So lots of the frail elderly patients have got sarcopenia. Their muscle mass is very poor. And actually, with help from the dietitian and the physios, this can be built up. Some of it is reversible, and so it's worth thinking about. Do they need aids? Have I thought about their bones? So do they need their bone health assessing? And have I thought about their footwear? Because actually a lot of people just fall because they've got really old shoes or someone else's shoes on, which is quite common actually. And so if we go back to our chap, so he's the one that had an unwitnessed fall, was in with a UTI, delirium, and is frail. Has a background of dementia, hypertension and AF, and he was found on the floor, walked back to bed, but now is more agitated. And you've been asked to go and review him post-fall and consider sedation. So, as we said before, we do an A2E assessment. So that was in our top tips, and his is very unexciting. So he's got a patent airway, his respiratory rate's fine, cardiovascular is fine, his BM has been done at 7, his GCS is 14, but that's normal for him. He's completely normal as he was before. But actually, when you have a look at him, he's got a really tender right wrist that they didn't notice initially. And when we have a look through his medications, he's actually not on any anticoagulation for his AF, and he's just on prophylactic dalteparin, and he's had some antibiotics. It's also always worth checking at this point. Fosfomycin is my least favourite drug at the moment because we prescribe it, and if the nurses don't have it available, sometimes it gets lost. So certainly on Lorenzo in Sheffield, sometimes we think patients have had antibiotics, and then a couple of days later we realise that they never actually received it. So it's always worth checking that their initial problem has actually been treated as well. So in this chap's case, he normally walks with a Zimmer frame, but they've been having a party on the ward and they were away because they've been decorating them, and it's getting to the night and they've moved them out of the way. So he couldn't reach his frame. And he's just in loads of pain because he's got this really sore wrist. So we give him some paracetamol and he starts to settle down. He goes for an x-ray and he's broken his wrist and he's put in a pot and things settle. So he actually didn't need anything to calm him down. He just needed some pain relief. So I think that's the first thing. Often as soon as someone's confused, just making sure that we don't miss pain after a fall. So if I go back to my funny little man and review this chap, starting at the top and thinking about his cognition. So we know he's got a delirium anyway, and this is where we ask the nurses to do the neuro-ops. Thinking about his medications, there's nothing I need to change. I'll check he's had his fostamycin, and I just need to make sure he's got plenty of analgesia and some more PRNs. At this point, I'd also check his vision, but he's got his glasses, it's fine. He could have an ECG. It's probably not an urgent thing, but we should make sure he's had one at some point now he's fallen. And again, it's easy to do a blood pressure, and they could do a lying standing just to make sure. It's worth thinking about his continence now. He may have been needing to go to the toilet, and that's why he's fallen, but now he has got a broken wrist. It's going to be difficult to use his frame, and he's going to need some more support with continence. If no one's helping him, he might get up and fall again. He has got sarcopenia, so it's worth referring to physio and dietitian to see if we can prevent further falls. We need to think about aids. So he probably is now going to need a gutter frame because of his pop and his wrist. The next thing to think about is bones. So we normally do a FRAX score, and the reason for this is we're trying to work out whether the person scores highly enough to have treatment to prevent further fractures. And then finally, footwear. So we need to make sure he's got some shoes on, or some of those really attractive red socks. And there's a gutter frame. So sometimes they can still use a frame, but they're just able to rest their pot inside. These take ages to get hold of, and the physios never seem to be able to get hold of them for a while. So there's a really high falls risk when people first have an injury, and if they're confused because they forget that they can't use their frame. So I was just going to talk very briefly about bone health. So this would count as a fragility fracture. So anyone that's fallen from a low impact trauma, so if you're standing up and you fall and you have a fracture, it would be classed as a fragility fracture. And most commonly we see wrists, the vertebrae and hips. And I guess the important thing is that we can recognise this, it's a warning, and we can give medication to try and prevent further breaks. And it's important because people fall and break their hip, and it's disastrous. So the NICE guidelines say that 10% of hip fractures die within a month, and a third have died within a year. So it's a big thing. If we are not offering people treatment to prevent these things, it has a big effect. So in normally not out of hours, normally in the day, we work out the FRAX score. So the FRAX score is developed in Sheffield, and you can just Google FRAX, F-R-A-X, and it comes up, and you just pop all the stuff, all the details for your patient into the score, and it literally tells you whether you should treat them, whether you should investigate them further, or whether they're okay and they don't need treatment. So there's options of bisphosphonates and other things like that. If it's a clear, definitely treat them. And for some patients, they're too frail, or there's other reasons they can't have it. But for a huge group of patients, this is how we recognise that they've got fragile bones, and we can prevent further fractures. So we use the FRAX score. So I'll move on to another person. So we've got this time a 72-year-old man. He's got a community-acquired pneumonia. He's come in on IV tazocin. He came in on a Friday night. He's had some bloods out for Sunday. Things are getting better biochemically. And the nurse asks us to come and review. It's just a routine falls review. He's had an unwitnessed fall, but he seems unhurt and he's completely fine. They're not worried about him. So his past medical history, he has Parkinson's disease, which he's had for 3 years, and he's known to have osteoporosis. His drugs are Sinemet, alendronic acid, and Adcal, so he's already on something to protect his bones. And normally he lives with his wife in a bungalow. He usually walks independently, but is mostly housebound. And his wife gives him a bit of support with ADLs, but he actually manages quite well. He's a non-smoker and no alcohol. So we go and do our ATE assessment, and the first ATE bit is really unexciting. Everything looks fine. and it could be quite a brief review, but we decided to just check on the medicines. We've noticed he's not quite right. So as he's talking to us, he's cognitively there, but his voice is very quiet. He looks very stiff, and you've noticed that he's incontinent. He's been incontinent of urine in the bed, which is not usual for him. And we do a medications review, and he's had his tazocin. They've given all the doses. He's on prophylactic dalteparin, and then when we get to his Parkinson's med, he's supposed to be on Sinemet, but actually we've seen that it's not been given for 2 days. And initially it wasn't given because it wasn't available on the ward. So the first 2 there was no dose available, and after that the nurses have omitted because they thought he had an unsafe swallow. And for the same reason, alendronic acid and Adcal have been omitted for an unsafe swallow. So effectively, what the hospital has managed to do is stop him having his Parkinson's meds, which has made his motor symptoms worse, which means that he now can't swallow and take his Parkinson's meds. And this does happen less so than it used to. But if somebody comes in hospital and they miss some of their doses, their motor symptoms very quickly get worse. And obviously that's a huge falls risk, and it's a huge risk of aspiration. And the non-motor symptoms get worse too. So people feel absolutely dreadful and they can't communicate properly. But the most important thing is it's actually life-threatening, because if we suddenly stop giving the Parkinson's meds, there's a risk of neuroleptic malignant syndrome, which is life-threatening. So it's important to make sure we're getting the PD meds. So if you come across anyone that's fallen and you think we could obviously thoroughly review the medications, and if you think they haven't had their PD meds, it's an emergency really. So pharmacy is supposed to issue them as an emergency med within 20 minutes, but if you feel that their swallow is now unsafe, there's the option of either giving an NG tube to give the meds or a reticotine patch. And actually the guidance suggests use an NG tube. In reality, we tend to use a reticotine patch more often. It's easier and it's sometimes less horrible for the patient. And there's ways of working that out, but just ask pharmacy or one of the registrars to help, and we just look it up normally. So I think the point of that was sometimes the routine reviews are, they can seem quite simple, but just always think about why the patient fell, because something might have gone wrong. So next case is you are asked to come because they have got a patient that they're struggling with. They've asked you to prescribe something to calm this patient down because they think they're going to fall if they carry on. You get to the ward and you meet this lady. So the fact is pharmacological intervention shouldn't be used before any other de-escalation methods. So all the normal stuff that that is difficult to do in the hospital. So people should be, the light should be turned on, always offer a cup of tea first, all of these things. But the nice guidelines do say, so if you do give medication, it's associated with significant risk. In this situation, if you are asked to come and prescribe something, is anyone brave enough to say what they would give in the chat box? In this situation, what would you prescribe? I can see Rachel's typing. I can only actually see Rachel on my screen. Nothing, okay. So if we get to the stage where this lady she's somehow found her rolling pin or her knitting needle and she's gonna cause harm to herself or us, and it's a genuine, they've got a great security team and they have tried everything, and she absolutely needs some medication because we don't know what to do. What would you go for? So Christopher has said lorazepam 0.5. I think if I was going to give lorazepam, I agree, I'd start with 0.5 or 1. And I have known people to give huge doses and it's not ideal. Has anyone else got any takers? So NICE guide, I can see Rachel typing, but she might just be working. So our NICE guidelines suggest that people, okay, so yeah, we've got another option. They have haloperidol, and someone else said haloperidol as well. Okay. So the NICE guidelines say people with delirium in hospital or care who are distressed and are now at risk to themselves or other people can have antipsychotic medication, but the verbal and non-verbal de-escalation techniques have to be done first. And we're not great at doing that in hospital. However, if they get, if they get to the stage that they're so distressed and they're a risk to themselves or other people, you can consider short-term antipsychotics. And the NICE guidelines actually recommend haloperidol. And it's interesting because there's other guidelines. The RCP suggest benzos, so they would go with lorazepam. But the official NICE guidelines are actually haloperidol. And I guess the thing to point out here is it can't be given to everybody, so just make sure you haven't got somebody with Parkinson's disease or dementia with Lewy bodies, because they can't have haloperidol. So the NICE guidelines say try haloperidol, and it says usually for 1 week. If I'm honest, I'd only ever give a stat dose and get them to review in the morning. There are some Cochrane reviews that have found that actually the antipsychotics don't do anything. So they don't reduce the severity of delirium, they don't reduce length of stay, and they've all got worrying side effects. So it's basically not clear. So there's risks with both. So with the antipsychotics, you've got a risk of aspiration pneumonia that's shown to be quite significant. There's a risk of falls and a risk of stroke. And then with the benzos, we've got a risk of delirium, respiratory depression, and again, a risk of falls. So when they've looked at these, it really isn't clear what to give. But the official NICE guidelines, if you're absolutely struggling, is haloperidol. But I think I'd always go with try nothing for as long as you possibly can. The only thing I would say is if you've got somebody, particularly in the elderly, often there's we don't always recognise that they drink quite heavily. So quite a few people have quite a few whiskies in the evening, and if they're falling in hospital and actually they normally drink, sometimes in that case a benzodiazepine might be useful because they're actually withdrawing, and it's not well recognised in the elderly population. I had a lady a couple of weeks ago that had whiskey in her porridge, so they have more alcohol than you might think. And I guess the other thing to say is if we do have to give medication as a last resort, we just need to be documenting really carefully what we're doing. So you need to make sure you say the diagnosis of delirium, what's been tried, so all the non-verbal things should be written down. The fact that we've actually thought about why they have delirium and we've tried to investigate and treat it. So, you know, they've had their investigations, we've given the antibiotics, but it's ongoing. And the patient is at risk to themselves or to someone else, and that they don't have capacity. And it's really important that we say at this point they don't have capacity. That's why we've jabbed them with a needle. And as we said before, it must be reviewed daily and stopped at the earliest opportunity. So I tend to just give a stat dose. I really don't like leaving the PRNs because I want to know when these things are happening. So it takes us back to thinking about some medications. So I guess, again, in the chat box, just think of the medications that you have come across that increase the risk of falls. There'll be loads, so just anything is fine. Yeah, antihypertensives, agreed. Opiates, agreed. And I think the thing to say, obviously always look at everything from an elderly population, at the elderly population, but it's really the elderly population that fall in the hospital, and a lot of them have been on antihypertensives for decades. And as their body ages, they metabolize them differently, and all of a sudden they don't need all of these things. And they get to, or they've sat at home and not really taken them, and they get to hospital and we give them to them. So a lot of these things, they may have been on for ages officially, but they don't need them anymore. So yeah, so opioids, diuretics, what's BBs?
Beta blockers.
What is it?
Beta block.
Beta block. Okay. I'm absolutely hopeless, sorry, with acronyms. Yes, okay, agreed with all of those. So basically, there's absolutely tons. Officially, the thing we worry about the most is the anticholinergics. So any medication that affect the cholinergic pathway are important to pick up. So they're the medications that patients complain of: a dry mouth, dry eyes, constipation, potentially retention. They can feel a bit blur, their vision can feel a bit blurry, and they can get a bit tachycardic. We notice in elderly patients that they can become very sedated, which in itself can lead to a risk of falls. They can become confused, and it can cause people to hallucinate. And in lots of studies, they've now shown that medications that have got anticholinergic properties have a really significant adverse effect on both cognitive and physical function. So people are more likely to fall because they're confused, but they actually have worse physical function than before they started. So it's going to be a really busy slide next, but you don't have to look at any of the words. So the Aging Brain Care, so the ABC group, made this massive chart, and it's literally this side of the left-hand column in each box is the name of medication, and in the right-hand side it's the brand name. But basically what they did was they looked at all the common medications that have got an anticholinergic effect, and they graded them. So the ones in the grade 1, they're a bit, what's the phrase? They're weakly annoying. By the time you've got to 3, they've got quite significant effects. So we've just zoomed in a little bit on the score of 3. So these are medications that have got a high anticholinergic burden. And again, don't worry about looking too closely. But I've just highlighted the top 3 that we see quite commonly. So many of our patients are on amitriptyline. I don't know who prescribed it all like a couple of decades ago, but loads of them are, and it's a nightmare. So we always try to wean people off if we can. And then oxybutynin and solifenacin for the bowel, for the waterworks. Again, loads of elderly ladies are on those, and it's got a really high anticholinergic burden. So if you spot one of these 3, it's definitely worth thinking about it, and just raising that. And if you ever think, this is an odd medication, I don't know whether this is something you need to worry about, you can just look up this ACP score or just Google the anticholinergic burden, and you can get this list. It's really easily available. So they're the things that we try to withdraw if we can. So I think the thing about falls that we kind of worry about the most is the head injuries. Certainly as an inpatient, everyone will have seen some horrible head injuries. And the thing you worry about the most is if someone's bled on their brain. So this picture is a picture of a subdural, and you can see blood where it's not supposed to be. And I won't go into the details of CT scans because it's dull, but you can see this is a disaster because the bit of ventricle that should be over here has all been pushed over. And so they've pushed the brain over to the other side. They've got midline shift, and this is significant, and they probably won't survive. So we're trying to avoid this situation, basically. So I'm going to write a poll in the chat. So if you open the chat, I will get you to do a poll, and it's anonymous, so you just have to vote. But I can't do it until real time. So I will give you the question: will you CT head this patient, yes or no? So they are anonymous, so you just pick, and then we'll be able to see the answers afterwards. So I'll pop it in the chat now. So the first patient is an 84-year-old who was medically fit for discharge, had an unwitnessed fall in the toilet, has a GCS of 15, observations are fine. She's vomited 3 times since the fall earlier, and there's a small hematoma at the back of her head. She doesn't normally take anticoagulation. Would you do a CT on this lady or not? Yes. So unanimously, everyone has said yes. Great. Okay. Next one. So I'm going to put a new poll. So don't answer on the last one. So the next one is a witness fall this time, and they watch the patient bang their head on the rail in the bathroom, but no obvious injury, and the GCS and the OBS are fine. However, they are normally warfarinized. So it should come back up now. So this time, would you CT head this patient or not? So everyone so far has said yes. Great. So next one. So this time we've got another unwitnessed fall, no obvious injury, and it's one of those dubious falls where we don't know whether to call it a slide or a fall, but the person is now on the floor by the side of their bed. All observations are absolutely fine, and they are complaining of no injury and they can't remember what's going on, but they normally take a NOAC. Do you CT scan in this patient? So I think so we've got a mix. Oh, it's exactly 50-50. Oh, no is winning. So I think if you asked the registrars on overnight, you'd get a similar response. So I don't think it's clear. It's really difficult to know. Yeah, so I think you've got the option of completely ignoring the patient and saying, oh, it's probably just a slip, they're fine. You've got the opportunity to say, no, let's monitor them really closely and keep an eye on their GCS. Or you can just CT them straight away. And it's really hard. I don't think there is a right or wrong answer. And some of these patients slide out all the time. So you effectively could be CT scanning them almost every day. And I think some quite defensive doctors would just do that. They say, you know, it's quick, we can just do a quick CT scan. And others would say, no, you don't need to. So the actual official NICE guidelines we follow are for head injuries. So the issue with this case is you don't know if they had a head injury or not. So you're basically guessing. And I think, yeah, so, and it also depends. You speak to radiology and some are happy to just scan and some don't want you to at all. And it's really difficult. So if you have confirmed a head injury or you've decided you're going to assume a head injury, you need to do a CT head quickly within an hour. If the GCS is less than 12, if it's less than 15 at 2 hours, if you think there's a fracture or there's signs of a basal skull fracture, so you get the panda eye sometimes if you can see obvious CSF leak, so new clear snot basically, and then the battle sign is, this is a picture of the battle sign, so a bruise like behind your ears. So if any of those are there, you need to worry about a basal skull fracture. If there's been any seizure, any neurological deficit, or more than one episode of vomiting. So the ones we've just spoken about, the first lady had 3 episodes of vomiting, so she would tick, we would definitely CT her head, which everyone did. The next person was on anticoagulation, and as you can see, if someone is on anticoagulation, even if they haven't got any of these other things, we do scan their head, but it's not quite as urgent, so you've got a bit longer with those. So has anyone got any questions up until this point? Talking a lot, sorry. Feel free to butt in. So I guess we've talked a bit about falls and falls reviews, which you do all the time. And then the other bit kind of on your curriculum is talking about syncope. So, oh, can't click forward. The definition is a sudden and transient loss of consciousness. And it's basically when you don't get enough blood to the brain, so your brain, you switch off. So you get a loss of postural tone, and it resolves spontaneously and you go back to normal. So it resolves completely without intervention. And I like to simplify things. So I like to think of it sort of broken down into bad stuff, which is red, and benign stuff, which is blue. So the blue stuff is postural syncope or neurally mediated symptom. Don't worry, that's fine. So these are the benign ones that we don't need to worry about. However, there are cardiac issues that we do need to worry about, because if we don't pick them up, patients could die. So we need to work out whether we think we need to investigate them or not. So the neurally mediated, sort of under the umbrella term of neurally mediated syncope, we've got vasovagal, so they're your simple faints. Then we've got situational, where people are on the loo or they're having their food or drink or something like that. So something triggers it to happen. And then there's carotid sinus hypersensitivity, where people are doing something like having a shave and they just irritate the carotid sinus and that causes them to faint. So they're all really annoying, but you may fall and hurt yourself, but they're not inherently worrying. So if we go back to the drawing, so that's the first kind of benign one. So next, if we look at the other benign cause of syncope, postural. So postural syncope occurs when your baroreceptor response isn't working. So if you can remember any physiology, which I struggle to, you've got baroreceptors that sit in your aortic arch and your carotid sinus. And the idea is if your blood pressure is dropping, they trigger and they give everything a squeeze and pick your blood pressure back up. If that's not working, your blood pressure just keeps dropping till you can't perfuse your brain and you drop. So this can be caused by drugs. So some of the antihypertensive drugs, you lose that reflex and people end up fainting. I'll try and talk quicker. And then if you have just bled out somewhere or you have had awful diarrhea, you've got less blood volume, so hypovolemic. You can have just a failure in your autonomic nervous system. So things like Parkinson's disease cause this. So they just can't regulate and their baroreceptors don't work. And then secondary autonomic nervous failure. So things like diabetes, where you've just damaged your nervous system and then you don't pick up. So people with PD or diabetes can have these just awful syncopal episodes that is really difficult to control. So one of the things on your curriculum is specifically listed as tilt table testing. So this is a picture of a tilt table. So if you're trying to investigate these causes of benign syncope, the first thing we always end up doing is a lying standing blood pressure. We can think about tilt table testing and carotid sinus massage. Basically, what you're trying to do is recreate the situation, prove that the person faints, and then you can say that's what caused it. We don't need to worry anymore. So tilt table is incredibly boring, and they literally just keep tilting people until they pass out. And often they do the carotid sinus massage on the tilt table test because you really need to have an arrest team available just in case. So that's how you would investigate those. So if we go back to this picture again, you're basically, if you can't convince yourself that it's one of these, you need to think harder about whether it's a cardiac cause. So the next thing is structural cardiac things. So these can be something wrong with the heart. So that can be the valve's gone wrong, the muscle, cardiomyopathy, there could be something in the heart like a mass, or it could be the covering of the heart, so the pericardial disease. And it also includes the non-cardiac causes, so things like pulmonary embolism and aortic dissection are stopping the heart doing what it should. So they come under that category. So for the next kind of heart thing, we just want to know whether somebody is having an arrhythmia. So the worrying cardiac things are, is the heart not pumping properly and is it firing incorrectly? Bradycardias are loads more common, and I guess the thing to say is that's why we do ECGs and echoes. So if we have detected something, we can do something about it. So for the bradyarrhythmias, if you've got second-degree heart block or third-degree heart block, there's a risk of your heart stopping. So we need to do something about it. If someone's had cardiac syncope and they have got second or third degree heart block, we need to act quickly because actually they may arrest. And then there are some tachyarrhythmias too, which are less common but can cause cardiac syncope. So just a recap. So we've kind of looked at the benign causes where we can demonstrate it happening. It's just sometimes you can't demonstrate it happening. And then the cardiac causes. And then to investigate the cardiac cause, you literally just need to look at the heart. So 12 lead ECG immediately, and then you can think about ambulatory ECGs. Sometimes 24-hour ECGs pick things up if people are getting lots of symptoms, but if people are getting symptoms once a week, sometimes you need to leave these on longer to pick anything up. And then echoes are just looking for structural heart disease. So I guess the summary is, if somebody has fallen, think about why they've fallen. Think about what you can do to prevent further injury or death, ideally. And I guess my kind of key take-home thing is just don't forget to do a thorough medication review. Think about what might have caused the fall or contributed to the fall. What can you stop? And then don't forget to give more stuff. So if somebody's now in pain, and just think about, just don't forget analgesia, and try to avoid giving anything to sedate them if possible. And then I was just going to point, this is my last slide, I was just going to point out there's a really great podcast called the MGT podcast. So if you ever listen to things going to work or whatever, they've got loads of great, they're really easy to listen to, and they're just really great topics. And you can, I don't know whether you guys have to mark off CPD, but you can fill it in and record when you've listened. So they're really good. And there's also a website, but it's Association of Elderly Medical Education, I think, the AMU website, and they've got some little videos and podcasts and things on there, and some of those are really good as well. And that's all I had to say. Sorry for talking quite a lot. Does anyone have any questions?
Sarah, I had a patient recently I was asked to see for a bradycardia. So the nurse felt this lady's pulse. She was completely asymptomatic. She'd come in with COVID, I think, but she was stable, medically fit. So she felt a pulse, it was 40, or so she thought. The ECG said it was 70, and she got, she was having runs of bigeminy and trigeminy. But reading back within the notes, she'd started having falls, sort of within this admission. And I was just wondering what the significance of this new arrhythmia. She didn't have these arrhythmias on an admission. I just wonder if you know, like, the relevance really of it, and if it would make her symptomatic enough to fall potentially.
I suspect some of the cardiac AMPs might want to answer. Has anyone got? Do any of you guys want to? You've probably got more experience.
I did refer this later to you guys, so thank you in advance.
I mean, from my point of view, I definitely would have been speaking to cardiology, and I think it is significant. But I don't know whether. I guess you've picked up a problem, and you need to have a look. And the problem with the way Sheffield works, I tend to just pass them on, and then they get further investigation. But I suspect they would want to be looking at that. Catherine, do you want to give us more information? You're potentially on mute. I can't actually see you. I'll stop sharing you. I can see.
Are you there?
Yeah, now we can hear you.
Yeah. I sometimes wonder, because the ventricle's not contracting properly, because the electricity is not getting through the ventricle as it should do, you're not getting the output quite as easily, which is why you're not getting the pulse properly at 70 beats a minute. And that's why you get a bit of lack of cardiac output sometimes with these ectopics. I don't know, that's me just wondering out loud, that's all. Reduce cardiac output just because the ectopics.
Yeah,
I don't know. I'm bad. Sorry?
We've got a registrar here.
I was just saying I agreed with you, Sarah. I probably just
yeah. What basically what I was going to say was, I'm not entirely sure what they do with them afterwards, but I suspect some of them end up with pacemakers. But someone may be able to correct me. But I would definitely refer those patients.
So, like, I did some bloods, and I did magnesium and that sort of jazz. And I think I missed off. Which one did I miss off? TSH. So I guess we're looking for causes to rule out reasons for this new arrhythmia, but I just wonder if there's anything else that I really should have done other than refer them to the cardiology people and do a bit of a blood workup. And would serial ECGs be of any benefit, or would you have done anything different?
No, so I guess you do a 12-lead ECG because you're trying to detect something that's gone wrong. And if you've shown it on an ECG, you've basically got that information. And you're right, sometimes things are reversible. So I've had patients before that are on a beta blocker and they've not had it for sort of 3 days and they're still really bradycardic. And the cardiologists have just been brave and said, no, I think it's still the beta blocker. So for those patients, we've kept doing 12-lead ECGs because we just want to keep on top of things, because it's a potentially reversible cause. And they were right, and it got better, even though by 3 days I was thinking, oh my goodness. But it's possible that things continued and they just needed a pacemaker. So for something potentially reversible like drug metabolism, I think it's worth kind of ongoing. But I think you're right, there's not an obvious reversible cause. I think they're just having some sort of weird heart arrhythmia. So I think if you've proven to do it, I don't think you need to have another 12-lead to prove it again. I think if you're worried about the patient, particularly if you think they might go into kind of a life-threatening arrhythmia, you can always stick them. I mean, it's hard to get a monitored bed in Sheffield, but if you are worried at the time, you can always stick them on the monitor, on the defib. And no one likes doing that, but I have done that before, if I'm honest. And you can record on the defibs if you need to, if something crazy happens. But normally by the time you say, I've got someone on the defib on the monitor there because you haven't got a bed, normally people start to move a bit quicker at getting a bed. But yeah, I don't think there's anything else I would have done. Anyone else? Does anyone else have any more questions? Sorry, I overrun a little bit. Cool. I will leave. Yeah, that's fine. I don't have any more to say unless you want to close.
No. Thank you for your time.
No problem. See you all soon.
Bye.
Thank you.
Thank you.
Thanks a lot.